Welcome to your second set of notes in Unit 8 Clinical Psychology. Today we are going to be focusing on anxiety disorders and also obsessive-compulsive and related and stress-related disorders. In the previous lecture that I did, I mentioned how at one point in time, anxiety disorders included obsessive-compulsive and the stress-related disorders, but in the new DSM-5, it has been split up into their own categories, but I am going to talk about them all together here. All right, so let's talk about prevalence. So according to the Anxiety and Depression Association of America, anxiety disorders are the most common mental illness in the United States, affecting 40 million adults ages 18 and older. So that's 18.1% of the population every year. And according to the National Institute of Health, an estimated 31.9% of adolescents between the ages of 13 and 18 had an anxiety disorder. Now this information, the adolescent information, is using the DSM-4 criteria. So that number could also include not just anxiety, but also obsessive-compulsive and stress-related disorders under it. But it's still a large number who are being afflicted by this disorder. So once again, I want to stress to you, this is about being a human being and about their life experiences. All right, so this is Tony Dorsett. He's one of football's greats, and he makes no secret of his fear of sleeping in the dark. He readily admits to it. He talks about how his life was growing up, how he potentially developed this fear of the dark, this phobia of the dark. But even today, as an adult, he still sleeps with the bathroom light on, with the door cracked, and always has lots of lights on in his house. So he has a fear of the dark, or a phobia of dark. And then this is John Matten. He is a football great as well. He coached the Oakland Raiders, and he was a player at one point in time. And he does a lot of football analyst now for ESPN. But he is well known that he refuses to fly. He has a fear of flying, and it's all because he had a severe panic attack on a flight. And so now when he goes from location to location for NFL football, he travels in a very luxurious bus. Now, I mentioned in a previous set of lecture notes and earlier in this set that there are now new categories of disorders. So in the DSM-4, the previous version of the diagnostic manual, anxiety was an umbrella term that included GAD, general anxiety disorder, panic, and phobias, plus obsessive-compulsive and trauma and stress, PTSD. In the DSM-5, anxiety now is only the umbrella term for GAD and panic and phobias. And then you have obsessive-compulsive as its own category, and trauma and stress related as its own category. All right, so let's now start discussing anxiety disorders. This is general anxiety disorder, panic disorder, and phobia. So general qualities, there's a worry, fear, apprehension, intrusive thoughts, meaning thoughts that they don't want but cannot stop from having, physical symptoms, and feelings of tension and turmoil internally. They seem to have an automatic quality that comes from within the person, like a knee-jerk, uncontrollable reaction. They don't want to feel this way, but it just happens. They would get rid of these feelings if they could. Now let's talk about the general anxiety disorder. This is prolonged, it's vague, it's unexplained, but it's intense, and fears that do not seem to be attached to a particular object. Highlight that, underline that when you put it on your paper, something to draw your attention to that it is not attached. This tension, this issue is not attached to a particular object. There's no telling where the anxiety has come from or why they are experiencing it. Studies show that between 4.1 and 6.6% of the population have experienced GAD, and it's more common among women than men and tends to become evident between late teens and early 20s. Please make note that with GAD, it is all the time. They are experiencing this anxiety. It's general anxiety all the time. It never goes away, nothing is triggering it, and they cannot tell you why they are having that anxiety. So GAD's clinical features, the symptoms that are present to get this diagnosis, you would have excessive anxiety and worry occurring for at least 6 months. The inability to control worry and considerable distress or impairment in social, occupational, or other important areas of life. So distress, okay, there's turmoil here in their relationships of some sort. Now, you need the presence of 3 or more of the following. On top of these other features, you need the presence of these following 3: restlessness, being easily fatigued, difficulty concentrating or mind goes blank, irritability, muscle tension, sleep disturbances. These features are occurring in a person. They are experiencing them, but they cannot tell you why they are experiencing these certain symptoms. The next one we want to talk about under the category of anxiety is panic disorder. The indicators are similar to GAD, all right, except that they are greatly magnified and usually have a sudden onset. So GAD is a slow build to that point, and you have to have them over a six month period of time, whereas panic disorder is quick onset. It's immediate. It's, and there is a trigger. It's more common among women and young people, and the clinical features are recurrent, unexpected panic attacks that last 1 month or persistent concern over having them again. These are attacks on the nervous system. Symptoms of a panic attack. These seem pretty obvious. There's shortness of breath, feeling smothered, dizziness, unsteadiness or faintness, trembling, shaking or sweating, racing heart, choking, nausea or stomach pain, numbness or tingling, chest pain or discomfort, sense of strangeness, fear of going crazy, losing control, or dying. So on that sense of strangeness, it's an unfamiliar place feeling. Like even if they know there's someplace they've been before, they still have this feeling that they're in an unfamiliar place. And our last one under anxiety umbrella is phobias. This is marked by a persistent and irrational fear of an object or situation that disrupts behavior. Okay, irrational. It doesn't make sense. It is out of proportion to the object. People with phobias know exactly what they are afraid of. This is how it's different than GAD. GAD is they don't know what's causing the anxiety. A person with a phobia will tell you exactly they know what is causing their anxiety, and it is their, like, I'm afraid of blank. But fears are out of proportion with reality and seem inexplicable and are beyond their voluntary control. I am afraid of snakes. I am phobic of snakes. Okay, I understand it's irrational. I understand it's out of proportion, but I still get the response, the anxiety response when I am confronted with snakes. Here is a chart that shows kinds of phobia. There is specific phobia, that's a fear of a particular object, that is me with snakes. There is social phobia, this is the fear of embarrassment in interacting with others. Social environment, and they tend to struggle with being in social environments if they have a social phobia. And then agoraphobia is the fear of entering certain fear-evoking or unfamiliar situations, which often accompany panic attacks. So avoid crowds where attacks could occur. So a social phobia is just like, oh, I might get embarrassed in this situation, but agoraphobia is they have a true fear of this unfamiliar situation, which will lead them to have a panic attack. To try to avoid having a panic attack, they just avoid all these new situations, and ultimately a lot of them end up being housebound and not being able to leave the house. Now let's discuss obsessive-compulsive and related disorders. First off, let's bust the myth about how everyone is always, like, hear a lot of people talk about how they are just, oh, I'm so OCD, and they like things neat and tiny, and they might wash their hands a lot, or they like to keep things clean. That is not OCD. That would be more like anal retentive. There are similarities between OCD and anal retentive tendencies or personalities or obsessive compulsive tendencies and personalities, but they are not disorders. You have to remember, you got to get the 4 D's and a U for it to be considered a disorder. Obsessive compulsive disorder is a persistence of unwanted thoughts. This is an obsession. They are obsessing about a certain thought and the urge to engage in senseless rituals. This is compulsions that cause distress. For it to be a disorder, there is a neurological connection that between the compulsion, that ritual, and the obsession. So intrusive thoughts, mother's son will die. That's the thought. That's the unwanted thought. That's the obsession. The mother is afraid her son's going to die, and the compulsion becomes that the mother will have to turn the light switch on and off a certain number of times. If she doesn't, then according to her thoughts, her son will die. So she has to flip the light switch on and off. Okay, that's what we are discussing here. There's no connection between the light switch and her son's health or well-being, but in her brain there is. So here is a kind of a graphic that helps kind of show how the cycle of obsessive compulsive disorder is occurring. You have the obsession, that's your intrusive thought, and then the anxiety and the stress from that obsessive thought. You then have the compulsive ritual. You do some sort of behavior. There is relief of that anxiety or that stress, and then they go back towards that homeostasis. The intrusive thought comes again, the anxiety kicks up, the ritual occurs again, the anxiety goes down. All right, so people with OCD do not seem to know anything with certainty. They don't trust their own senses, so they do things, compulsions, rituals, over and over again. They don't trust their own decision making. Therefore, what part of the brain would a biological psychologist say is affected by OCD? They don't believe their brain. They don't believe their decision making. So then you have to go, where's decision making occurring in the brain? I hope you said frontal lobe. So here is a brain image, a PET scan of a brain of a person with obsessive compulsive disorder. High metabolic activity, the red in the frontal lobe areas involved with directing attention. This just goes to show that it is the frontal lobe that is being affected by this disorder. Now we're going to discuss some OCD related disorders. We're going to first start with the body dysmorphic disorder. This disorder used to be listed under the somatoform disorder because they were of the body, but they now are under the OCD label because there are compulsions. So the body dysmorphic disorder. This is a preoccupation with an imagined or exaggerated defect in personal appearance. So people with this disorder will look in the mirror and they will see that their nose is disordered. They will think that their nose is like giant, or their body parts are out of proportion with the rest of themselves. They are not in real life like anyone else looks at them, and they are in proportion, but that is what they are viewing. That's what they're perceiving when they see themselves in the mirror. Its essential feature of BDD is the belief in an imagined defect in appearance. So like a larger nose is exaggerated, and they start to obsess over the fact that their nose is large. And so this is that intrusive thought, which leads to anxiety, and then they develop a ritual of some sort to lessen that anxiety. You have hoarding disorder. This is the persistent difficulty discarding or parting with possessions because of a perceived need to save them. There's a lack of value on these items though, because they just end up being piled everywhere. The distress at the thought of getting rid of the item, that's the anxiety. That thought of, if I get rid of this, that causes them anxiety, which then leads them to a compulsion to hoard it. That's their compulsion, is to hoard it. Trichotillomania is hair pulling disorder. It involves recurrent irresistible urges to pull out the hair from your scalp, eyebrows, or other areas of your body despite trying to stop. And this is of the body, so hence the reason it used to be under that somatoform disorder. but they have intrusive thoughts, which then lead to the compulsion. And then exoration disorder, this is skin picking. Repeated picking at one's own skin, which results in skin lesions and causes significant disruptions in one's life. It disrupts the life. It is an intrinsic thought of they have to pick at the skin. Something is causing them to pick at the skin, and therefore they have developed a compulsion. So let's spend a little bit time here on body dysmorphic disorder. It's a preoccupation, is time consuming. It's often being about the shape or size of the facial features, acne, spots on the skin, wrinkles, thinning hair, or scars. Individuals with BDD experience marked distress over their supposed deformity. Feelings of self-consciousness about their defect may lead to avoidance of work or public situations. So they could develop a social phobia over this body dysmorphic disorder. Individuals with BDD experience higher rates of major depression and suicidal tendencies. And BDD typically becomes evident in adolescence and affects males and females equally. Now remember, in adolescence, their appearance becomes kind of the center, like they are very concerned about their appearance, and this is why it tends to make the appearance at this, it tends to appear at this point. So here is some examples of what individuals with BDD see when they look in a mirror, and they were asked to draw. So clearly in this first image, this individual has body dysmorphic with the ears and potentially with the nose. And then the other individual has an issue with her face of some sort. But this is what they see when they look in the mirror. This is clearly not what they look like, but this is what they see. Then let's also talk about human Barbie. This is Sarah Bird. She's 50 years old from the UK. She has had over 100 procedures costing $1.4 million for various cosmetic enhancement. Recently in the news for allowing her 16-year-old daughter to begin Botox treatments. She has seen something wrong, and so she has gone the medical route to fix it, to adjust it, to make it so that what she is viewing in the mirror is no longer there. Clearly, time-consuming leads to this compulsion. In her case, it is cosmetic enhancements. Okay, now we're going to talk about trauma and stress-related disorders. This will mostly focus on PTSD. So post-traumatic stress disorder, this is 4 or more weeks of the following symptoms constitute post-traumatic stress disorder. They have haunting memories, nightmares, flashbacks, social withdrawal, jumpy anxiety, sleep problems. And they have these issues because they cannot get away from whatever has caused their traumatic stress. So from the event, they're having flashbacks on it. So it's constantly there causing this disorder. Now, resilience to PTSD. Only about 10% of women and 20% of men react to traumatic situations and develop PTSD. Holocaust survivors have shown remarkable resilience against traumatic situations, and all major religions of the world suggest surviving a trauma leads to growth of the individual. Just because you have a traumatic experience does not mean you're automatically going to develop PTSD. You're not going to end up with this disorder. Findings have supported that. Don't think how you are handling a traumatic event means that you automatically also have PTSD. Just because you might think you're not handling it well, it doesn't mean that you aren't. You probably are. Your body is processing it. Please make note that with PTSD, there's the event, and then the disorder starts to occur after a time period. It is not immediately following that traumatic event. So acute stress disorder, this is very similar to PTSD, but starts immediately after the trauma and lasts from 3 days to 1 month. PTSD is like, you got to have that experience for 4 weeks before they will consider it to be PTSD. So it's very similar, but it's immediate. It is instant, very quick in regards to when the trauma happened to when you will be dealing with acute stress disorder. And it's more intense than PTSD, but it's shorter lived. These were previously considered anxiety disorders, but are not anymore due to patients not always experiencing anxiety. Rather, they may experience anger, aggression, or disassociation, and others. The person who is suffering from acute distress disorder is suffering from a traumatic event, but they're not responding necessarily with anxiety, and therefore it can't always be labeled as an anxiety disorder. The learning perspective. Learning theorists suggest that fear, phobias, conditioning, so fear conditioning leads to anxiety. This anxiety then gets associated with other objects or events, stimulus generalization, and gets reinforced. Fear responses, investigators believe, are inoculated through observational learning, and young monkeys develop fear when they watch other monkeys' fear of snakes. So this is about phobias. Phobias can be learned. They're getting reinforced. And so we go back to the previous set of notes when we talked about how would we do a treatment. It's behavioral. We have to unlearn certain responses is what they're talking about here. Now, the biological perspective is generalized anxiety, panic attacks, and even OCD is linked with brain circuits like anterior cingulate cortex. That anterior cingulate cortex is the specific part in the brain that is being affected. With OCD, it is also affecting the prefrontal cortex. Okay, so this wraps up your second set of notes over all the anxiety disorders along with OCD and stress-related disorders. If you have any questions, let me know. Otherwise, don't do anything too stupid. Bye, guys.